Hi, folks. We're going to go ahead and get started because we have some people online too. I don't want to hold up people online. So I'm just going to give a brief introduction, the usual introductory slides, introduce David Green, and then we'll move along from there. First, I want to thank everyone for being here. I know it's spring break week at Hopkins, so it's a tough week, but it's worked out this way. So appreciate all of you being here and everyone joining us online. A brief housekeeping items as usual. I'll go through briefly if I can click. Join us in person, hold questions until the end, but actually this is an exception. Dave and I had breakfast this morning. We love to make this interactive possible. I will constantly be pinging Dave with questions throughout. So I think questions anytime, all the time are great. This is not your typical research presentation in a good way, and I'll go over that for the end why that's the case. So questions anytime, including those on chat. Feel free to ping along anytime with questions, and then we'll have more of a free form discussion, a little more along the lines of what we did KRLU a few months ago from Google. There's closed captioning in Zoom, links below. Seminar is being recorded, and then there's an email address or put chat if any technical difficulties. This actually, crazy enough, is actually our last formal seminar for this year. And then next month is a little different because it's our annual Cochlear Center Research Day, which is going to be fully in person, no hybrid option available this year. And this year we're mixing it up where the general theme of Cochlear Center Research Day next month is sort of thinking outside the booth per se for how we deliver hearing intervention to aging populations. The morning will be 4 short talks by some of our key collaborators and one of our own faculty here. People we've either collaborated with or have trained with us around their approaches for thinking about addressing hearing in sort of outside the booth populations. Then we're thrilled that Devet Swempol, co-founder of HearX, in South Africa and professor at University of Pretoria is flying out to join us for the day as well, giving his talk. There'll be a poster session in the afternoon with recorded feedback for all the trainees who are actually doing posters. So hopefully be much more interactive. And then there'll be a happy hour as well. So that's actually technically our last event of the year, but it's not technically a real seminar because it's an all-day affair. All right. So I am really, really happy to introduce David. And I'm trying to click the last slide here. Oh, thank you. Yep, got it. There we go. So David, I met David over a decade ago in 2011 when I was just joining the faculty, and I was introduced to him by one of my closest mentors early on in my life was David Freeman, who was an ophthalmologist epidemiologist. And I was telling David this earlier today at breakfast and also last night. David really influenced me really early on in thinking very much outside the box of how we leverage public health. So I think public health, a lot of times the way you guys, trainees think about is there's the research, and you might broaden a little bit, think about policy, about making impact. And I was really struck by David very early on because even though he has an MPH, his approach to public health impact is very much through the market, through being a social entrepreneur, a serial startup sort of entrepreneur that has had a huge impact on so much scale that he'll talk about more. And I was thrilled that David came today because I think as a trainees that come through the program, we always think about, again, research. Research is wonderful, but research is fundamentally for me in the end of tools to an ends and to a means, basically, right? Or sorry, research is a means to an ends, basically, for achieving impact. And there are many ways to have impact. And I think what you're going to hear from David over the next 45 minutes, an hour, and it'll be sort of free-form discussion, is how social entrepreneurship through a market-based approach can have a huge boots on the ground impact, maybe even more so than research in many, many cases though. So I'm going to highlight a couple things and he'll probably go into much more about this, but sort of the origin story that I always relate about David when I talk about David is, and he'll talk about some more intraocular lenses for cataracts, hugely expensive. Johnson & Johnson, the average price back then was $300. And through starting a company in India that now has about 10% of the world's market share, brought the cost down to about $1, right? So again, very outside the box approaches to how we impact public health that goes beyond research. He did the same thing for surgical sutures. How I got to know David about a decade ago was when he had just started up a company doing hearing aids as well. And even though that's been more of a minor focus, I think, for David, mainly it's been on the vision side, there's so many lessons to learn. I think that all of you guys will appreciate as we hear from David over the next 45 minutes. So thank you for joining us, David.
So how long should I talk and how long do I get to questions?
45 minutes, and then but we can make it free form of questions per hour. Yeah.
He said 45 minutes. Okay. All right.
Okay. Thanks, everyone. Can you hear me okay? Yeah, okay. All right, so let's see. Okay, so when I was in the School of Public Health at at that other School of Public Health, University of Michigan, what I learned is that the main issue was who should pay. And I think I've spent the better part of my work life looking at why do things cost so much. So that's sort of the key inquiry that I've made. And I've discovered that things don't really cost that much to make. Even, sophisticated medical devices like pacemakers, or I dare say cochlear implants. Okay. Okay. So, what matrix do you live in? Oh, there's some kind of feedback. Oh, I think you're all familiar with the movie The Matrix. I think the first one was the best one. And, Neo all of a sudden wakes up out of what he thinks is reality to discover that there's another reality. And that's kind of what my journey has been, to realize how the whole medical industry works. And when you really demystify costs and look at supply chains, there's a huge amount of margin that is non-value added that you can take out to make products affordable. So that's kind of what I've spent my career doing. So the way I got going was I started as a volunteer for Save a Foundation, and then I worked with them for many years. I'm actually still a consultant to them. They're based out in California, and my job was to help develop the Aravind Eye Hospital in India, which I'll be talking about, and also the Nepal Blindness Program, which is the national eye care program of that country. And I started getting donated medical products, chief among them intraocular lenses. And then I started recruiting ophthalmologists to train in the modern surgical technique for intraocular lenses. And what happened was these programs, people started coming earlier for surgery in greater numbers before they were economically blind, when they could afford to pay something, knowing that a much better visual outcome was possible with the implanted lens versus thick cataract glasses, which research showed 56% would lose or break within a year of surgery. And so as these numbers mounted and as these programs started to become self-financing, really from all these donated intraocular lenses, the donations dried up. And that's when I looked to make intraocular lenses. And just so you all know, I had no formal background in really anything. I mean, my degree was Bachelor of General Studies, and my public health degree was Health Behavior, Health Education. But I felt that it was key to figure out how to make intraocular lenses. I was getting accused by many, including the director of the National Eye Institute here in the US, of getting programs addicted to a high-tech fix, which ultimately wasn't sustainable. So I was dealing with a lot of criticism, and so I set about to figure out how to make intraocular lenses. And I had been a carpenter before public health training, and so that helped me a lot. So I actually went around and visited all the companies that had been donating, and I said, gee whiz, how do you make these little things? And so I could see their manufacturing, and that gave me a context to evaluate the different technologies that I was looking at. And the one that I picked, the group I picked for Auralab's first foray into intraocular lenses was a turnkey lab where I could sit down and actually make a lens and compare it to lenses made in America and see that the quality was the same. So that's basically how I did it. So once we got Auralab up and running, that laid the foundation for for the whole trend of sustainability in eye care. Products represent the biggest cost variable in many procedures in the developing world. And what we did is we lowered the price point dramatically to enable a lot more training programs to take place for surgeons learning intraocular lens implantation. And that led to so many programs becoming self-financing. And so we went from a donation to what I call sort of the middle way of capitalism model, which I'll talk about later. And I'd gotten maybe 200,000 lenses donated over an 8-year period. And today, Aura Lab sells about 3.5 million lenses and has 10% of the global market share, selling very low-cost lenses where there's lots of competitors in that price range. So again, it's a key theme of how changing the competitive landscape with pricing as your weapon brings about the transition. Now, one of the issues that we'll talk about later is how to do that in hearing care, because I've helped create a really affordable high-end hearing product, but the question is how do you stimulate demand for that product? And Dr. Lin and I have been discussing that for many years, and also this morning, still haven't figured out how to do that properly. Okay, so this is a picture of an intraocular lens in an eye. So in this talk, I want to show that it's lessons I learned in eye care and how they might apply to really any type of care, including hearing care. And that is that what we've learned is it is possible to serve all economic strata, especially the poor, and still be profitable. I want to share with you examples of social enterprise healthcare providers, as well as manufacturing companies where we've created sustainability to address low-income populations in many diverse economies. And I'll talk about the key elements that made all this possible. This is an ecosystems approach. And so I've been able to touch the development of clinical models, business models, even introducing new surgical techniques, wrapping around those a business model with tiered pricing, where we've been able to have free be the lowest price and have tiered pricing based on differentiated products at differentiated price points. And so we've been able to do this just through the intersection of service delivery, innovation, gaining control of technology to be in control of pricing, and financing, matching it up with affordable financing, whether it's grants, combination of grants, debt, and equity, to make the startup costs affordable and manageable. And probably the most important thing is in these entities that I'll be talking about, how do you instill values about serving others, about how to have empathy for others? And one of the big questions that I've mulled over is there's individual empathy that we all know that we can have. How do you create empathy as part of an organizational imperative? And so that's really for the longevity of these projects. How do you stay true to social mission of serving others with affordability? Okay, and so here's a key point that underlies everything that I work on. It's about maximizing distribution while being profitable rather than maximizing return on investment at all costs. And as you know, so many companies, public or private companies in America or really anywhere, usually have the legally binding imperative that they have to maximize return on investment to shareholders. And so some of the things that everything I've developed has to do with how to maximize distribution while being profitable. And some of the programs I've developed are the most profitable eye care networks in the world, even though they're nonprofit and even though they're doing close to 50% for free or low cost. So it is possible. Okay. All right, now here's what's underlying everything. and that is the incredible wealth disparity. So
That last slide though, you mentioned before, so if you're a publicly traded company, to create value for your shareholders, I mean, there is very much this notion of return on investment of all costs, right? How do you reposition that for that, assuming it's publicly traded? Is it just a matter of valuing long-term value, or how do you prioritize that if it's a publicly traded company?
the way that I've done it is to convince companies that there's value to have differentiated pricing for lower income markets in order to gain market share. So I don't argue with them based on altruistic values. I argue with them based on capturing market share where they have to go to a lower price point. And I've done that successfully with Medtronic in India for pacemakers for the Healthy Heart for All initiative. And Oralab has done it. Oralab had an unsolicited offer from Alcon to buy them. Alcon's the largest ophthalmic company. And that we didn't sell to them, but it was a demonstration that by being able to figure out how to reach the low end of the market and show that it was profitable, they basically wanted to buy that market share. So that's how it is for all these large corporations. If the developing world are the horizon markets, they have to price for affordability, for going after the market potential, which are lower income people.
I mean, I guess I'll relate, this comment back to what you just said on your last slide, which I really liked, which is having kind of, the values of empathy within a company. So I guess you're kind of arguing that at some level, this doesn't happen. But, are you, is it conceivable that you can extend it even into a publicly traded company? Or are we trying to say we're trying to make these the same thing? That, that the values of empathy can align properly with the typical financial model that a publicly traded company would have?
No, they don't. That's the problem. But there are, you can be legally incorporated as a B Corp, where you are not legally obliged to optimize return on investment. And there are publicly traded B Corps. So, and there's starting to be similar types of legal constructions in other countries besides the United States. I know Japan is considering something like that. I think it exists in other countries. So that's a movement in the right direction. And I would say that shareholder pressure on publicly traded companies to be more social makes these companies look to do things that make the shareholders happy. And I see that quite a bit as I go out and engage with larger corporations for strategic investment, strategic alliances. So there is shareholder pressure. Yeah. Okay. All right. So basically 10 guys own more wealth than the bottom 3.1 billion people. And the wealth gap keeps growing. And that wealth gap, if you look at the industries that concentrate wealth the most, it's financial services followed by healthcare. And that's all in this, Oxfam puts out this report every year on the wealth disparity. So that's sort of the underlying problem of industries charging as much as possible to aggregate wealth in as few hands as possible. And that kind of leaves the rest of humanity behind. So one of the big issues that I face, I don't address income disparity, I address pricing disparity and how to make things affordable to those low-income people. And if you look at the whole medical world, if you look at just about any medical realm or a medical device or therapeutic realm, it always consolidates down to very few companies. Like with suture, it's like 2 or 3 companies, one company having 85% of the market share. For hearing aids, I think it's 4 companies have 85% of the market share, 5. But didn't one merge recently?
There used to be 6, now it's 5.
6, okay. So, and if you look at intraocular lenses, it's 3 or 4 companies. I mean, if you look at pacemakers, it's 3 companies. So big companies buy up competitors, either to get them off the market or to just become bigger and not have any competition. And that's what removes price competition. And there's all sorts of price fixing going on because nobody wants to upset the apple cart with competitive pricing, because that means that you start a price war and then everybody's margins go down and you make less money, and of course your shareholders get upset, right? So that's kind of how things are. I mean, that's how I see it. And then there's a lack of market incentives for most medical device companies or therapeutics. They're always going after an early exit for somebody to buy them up. I mean, that's how the whole system here at Hopkins is set up. You develop something, Hopkins allows you to license it, and then you develop it and you figure out how are you going to do an IPO, or more likely, how are you going to sell it to one of the big players. Okay, so that's okay. So basically, there's a lot of human suffering. Capitalism, in many instances, has run amok, and income disparity is growing. Those are the sort of the underlying forces. But how do you use the tools of capitalism to address human suffering? How do you have the right type of finance, lean manufacturing, competitive pricing? And then how do you have the values that permeate your organization to stay true to pricing for affordability? And then how do you prove out that there are markets at the base of the pyramid so that other competitors come in and serve those markets? How do you create a competitive environment to serve low-income populations? So the price is the issue, not cost. Almost everything I have made ends up costing just, like when I work with Medtronic, I figured out that, the lowest price pacemaker for a couple $1,000 costs $80,000 to make with technology that was already out of patent. Or with intraocular lenses, as you'll see, when we started, the price point was, $300 to $500, and our lowest price lens today is $1 for CE mark. So there's all sorts of convolutions to kind of prove that, our R&D is so much, or this or that, when really it doesn't cost that much to make. And so you have to be able to have your strategies for figuring out, well, how much does it really cost to make something? And then price it affordably. So before I dive into the different eye care programs, here's just a list of kind of what the major causes of blindness are. And I spent most of my career addressing cataract, but now I'm working on corneal disease, diabetic retinopathy, macular degeneration, and also uncorrected refractive error. So I'll have some slides that show how we're focusing on that. But if you look at eye care, in comprehensive eye care, most of the money is made from cataract surgery, same here in the US, and optical, followed by intravitreal injections for diabetic retinopathy and macular degeneration. So how do you focus on those to optimize your revenue, your margins, but also price for affordability for those that can't afford to pay so much, or free for those who can't afford to pay anything? Okay, so I'll talk about examples of service delivery. So here's some of the leading eye care programs that I've helped develop. And this slide is, I think it's a little bit outdated. I think it's up to like close to 3 million that this network is doing now. And that's a lot of surgery. That's I think 10% of the global market share. Aravind, which I'll be talking about, really leads the way, but India, China, Nigeria, now Egypt. I've done this model in Vietnam, Malawi, Kenya, Nigeria, Cameroon, Mexico, Guatemala. So this model of developing sustainable eye care with tiered pricing, differentiated products at different price points, where free is the lowest price, can be applied just about anywhere. I have a colleague who's applied these principles in Burundi, which is one of the poorest countries in the world. Nepal is one of the poorest countries of the world, and it has better coverage in ophthalmology than the United States does per population, from a very well-developed eye care program that many organizations contributed to creating, and where there's a high level of sustainability based on earned income. So you can do it in very poor countries. Here's Aravind, which they just keep growing and growing. And so this is 5.6 million outpatient exams. That's both new and old. 688,000 surgeries and 49% free or steeply subsidized. So they're paying below cost. And they're probably the best example. And that's Aravind is where I really learned a lot about creating sustainable eye care. And from there, I helped develop these other sustainable eye care programs. Okay. Okay, so you can see it's a big network, 14 hospitals, 105 vision centers. Those vision centers bring eye care to a very local level, where it's staffed by an ophthalmic technician. It relies upon teleophthalmology so that every patient gets to see the eye doctor after the initial assessment. And some of my work now is introducing diagnostic algorithms into these vision centers, and where we're finding out that it's actually more accurate than the technician or the ophthalmologist detecting disease. So I think there's a big future for artificial intelligence, especially for the diagnosis of eye disease. And this gives you, this is from a couple of years ago, 2017, 2018. Those numbers have all risen dramatically. This is back when they were doing, I think, 475,000 surgeries. You can see that even though they're providing 50% for free or below cost, they still make a substantial profit margin. So off of 50 million, they made 20 million in profit, even doing all that work for free or below cost. So that just sort of demonstrates that it's possible. And I one of the questions you might be asking is this possible outside of eye care? I think the answer is yes. We're anywhere where there's procedure-oriented medicine, cancer, orthopedics, baby deliveries. Those are all the big ones where it's very procedure-oriented and you can have high volumes. Here's another group that I helped develop. This is the Lions Aravind Institute of Community Ophthalmology, run by Tulsi Raj Ravila. And so they've helped over 367 eye hospitals from 29 countries, contributing to about 800,000 additional surgeries a year. So they've done all these amazing training programs to help other eye care networks become self-financing. And this is what's missing in hearing care, I believe. It's like, how do you develop leading institutions that can develop and innovate into the world cost-effective techniques, both business model, clinical model, and financial models for reaching the market potential. So that's something to think about on the horizon for the Cochlear Center.
So you mentioned in your last slide, your very point, you said procedure oriented though. So why procedure oriented specifically, as opposed to let's say another flip side, like primary care, not procedure oriented, also critical, more intensive in terms of personnel? It's just because it's harder to scale that model?
Prevention people don't pay for, unfortunately. Procedures they do pay for. So if you perceive you have a need and you need a procedure, you're willing to pay for it.
Gotcha. You talk about, David, like, why has this developed in ophthalmology and has it developed in other areas of healthcare? And if so, why is it just chance that it happened in ophthalmology, or is there something about, the model of care that we deliver that makes it uniquely suitable for?
I
of
think
work?
it can be reproduced in other areas, but I think ophthalmology, I think if you look at cataract surgery, Medicare pays out more money for cataract surgery than any other surgical procedure. If you look at China, Vietnam, Malaysia, Brazil, all these large insured markets, cataract gets more money than any other surgical procedure in those markets. It's either, number one or number two, simply because there's so many cataract patients. And so and then of course there's refractive error and people needing to buy eyeglasses, which is the other big income generator. So I think that there are unique aspects about cataract. A cataract surgeon who's really good can do 6 surgeries an hour with the right type of efficiency. And as your volume goes up, your per unit cost goes down. And I think also, I'll get into it later, India has a very price competitive ophthalmic industry where all these companies came up in the wake of Oralab to compete with Oralab on price point. And I believe that price competitive market that grew up in India and now touches many programs globally is what engendered the eye care revolution, because intraocular lenses went from $300 to $1 for a CE mark lens. And whenever you reduce in developing countries, if you can reduce the cost of the device or the therapeutic, that's what the bulk of money is for in insured systems and uninsured systems. Here in the United States, it more relates to the labor cost rather than the device or therapeutic cost. But in these other countries, it's mainly the stuff that costs so much. So if you can reduce the cost of that stuff, so how do you have a revolution in pacemakers? Because there's a huge amount of arrhythmia that's untouched. How do you bring down the cost of a pacemaker? How do you bring down the cost of a hip implant or whatever? Okay. So here's, let's see if this works. This is, nope, it didn't work. This is an eye camp at Arvin, and they see hundreds of thousands of patients. They organize it with sound turns off when they all go to the hospital. These are all the things that are done during an eye camp where they'll see anywhere from 300 to 3,000 patients. And I think last year they saw something like 200,000 patients in patient counseling, and then they're brought immediately to the hospital. So because of Arvin's reputation, everyone knows if they go to an eye camp and they need cataract, they'll be well cared for, and families are okay sending their relatives off without any accompaniment, because they know Arvin will take care of them. So if they have the eye camp Sunday, they go to Arvin Sunday night, they have surgery Monday morning, and then Tuesday morning they go home. And that's how they do a lot of surgery. Okay. And this is just what Arvin looks like on the inside. This is the Seva Foundation, who I've worked with over the years. This is a program that I helped develop. I I raised sort of a debt financing fund with Deutsche Bank, which I'll talk about later, but accompanying that, I created a capacity building grant fund. And then SAVA continued with raising grant funding to help living examples of sustainable eye care train other programs. So now they've trained over 100 programs in how to be self-financing through 10 mentors, and have been able to increase surgery dramatically. And here's some data I had from 2010 to 2015. You can see that over baseline, they were able to increase with 53 hospitals to add on close to 100,000 surgeries. So what do these programs have in common? It's the choice to use profit and production capacity to serve the poor. It's tiered pricing. It's operations research to come up with improving quality and efficiency that's constant and ongoing. Sharing with others freely to spread. Leadership, ethical qualities located in areas of higher population density, although there are some examples of rural programs that really reach large populations. And then they generally are in control of the ability to generate revenue, choose how it's spent, hire and fire staff, and competence to manage. So they're in control of all the elements of production. Okay. Now I'm going to switch and talk about technology, and I'll talk about Aura Lab, which I mentioned early in my introduction. So they've helped over 35 million people see to date, and from a public health point of view, it's like none of those patients know who I am, but I counted up how many people get helped every day from the programs I've touched and helped, and it's something like 13,000 people a day. So, what I did is I basically applied public health mentality to products, to lower pricing of products, and figure out how to scale those products through the right service delivery models. So here's an example of some of the price points of our products compared to what's on the market. And Aura Lab is profitable. It has a 42% profit margin, and it even pays taxes. It's a nonprofit, but all of its competitors who are for-profit got the Indian government to breathe down their neck and make them pay taxes, but they're fine. They don't mind doing that. They still make good profit. And then here's how we started, and I think there's over 1,000 people. And the guy on the left, Gary Goins, he unfortunately passed away a few years ago, but he's the one that created the turnkey lab that got Aura Lab going. And then I'm on the far right, and those are all the young women that we trained. And now it's like they had to have like 1,000 people working there. And this is what some of the manufacturing looks like. This is the lathing of intraocular lenses. This is suture, grinding the tip of the suture needle. This is some of the pharmaceutical manufacturing. This is sutures, putting the thread onto the needle. And here's how Aura Lab played a role in Aravin's growth. You can see that we started Aura Lab in '92, and this is just up to 2008. Of course, it's a much bigger curve since then. This is old data, but I didn't have a slide with recent data. So you can see how once we got into production, how the volumes increased dramatically.
Sorry to interrupt. Can you comment of any of the, if any barriers to entry were experienced by you during this process of creating this company?
Yes, I mean, I think that well, one of the barriers is in this slide. So you're talking about barriers to entry to getting into technology development.
Not only in terms of technology development, but any patents on drugs or the devices, or any patents, drugs, devices, any government seal of approval that you need to do?
Yes.
All the
Sure. So when we first set up Aura Lab, we didn't pay attention to any intellectual property. We just went ahead and did it because we didn't know better. But don't tell anybody. When I did the hydrophobic acrylic lens, I found the inventor of it, Amit Gupta, who unfortunately he passed away just this year. He was the original patent holder on hydrophobic acrylic. He had developed it for Ioptics, which sold to AMO, which sold to J&J. It's now J&J's leading product, and so he guided us in our development. And we created a non-infringing material and even figured out how to make the raw material. And then we had the help of a intellectual property firm, Morrison Forster, to basically create intellectual property that was novel and non-infringing. But more importantly, we had their guidance to avoid violating trade secret law, which is more of an issue than patent infringement. So all the people that we worked with had NDAs that were still in effect with the companies that they had worked with, but we figured out how to basically get all the knowledge that we used to create the product into the public domain so that we could point to where it existed in the public domain, the legal definition of the public domain to show that we weren't violating trade secret law. And I would say that a lot of the developments that I'll be talking about coming up in this show, a lot of it is wrapped up with understanding intellectual property. How valid is somebody's intellectual property? Is there a way to go around that? And so I work a lot with intellectual property lawyers to basically get them to work with us, do all the research to write what's called a freedom to operate letter, which means that they're putting their own liability stamp saying, we've certified that this idea does not violate any intellectual property, doesn't infringe or violate trade secret law. So now my work and all the things I'm doing is more and more in that realm. On the some of the impediments have been companies. So like if you on this slide, Suture, J&J sued Aura Lab when we beat their main medical device company, Ethicon. They sued us when we beat them out on a contract with the government of India. They lost, they appealed, they won, and we took it to the Indian Supreme Court and ultimately won that case. But in the meantime, they had lowered the price of their product from like $240 down to $23, and they beat us out on the next bid. So it's an example of how price is used as a weapon in favor of the consumer, which hardly ever happens here in the United States. So that's what we were able to do. We were able to get Ethicon, which controls 85% of the market, to completely change their pricing to be more appropriate for the developing country setting. And then the same with intraocular lenses. When we started Aura Lab in '92, India was doing something like 800,000 cataract surgeries, mainly without intraocular lens. We had a lot of training programs going where we developed lens, training and implantation. And by 2000, all these other competitors had sprung up and were competing with us. They actually competed our price down to a couple of dollars at that point. We started at $10, they competed it down to a couple of dollars. But the main thing is that consumers benefited because the surgical volume for cataract in India went from like 800,000 to 5 or 6 million in just a few years. And now it's somewhere between, between 7 and 8 million. So again, it's how pricing changes the whole competitive landscape in favor of the consumer. And then here's an example, and this is an old slide that I did where I figured out that our costs were the same as Alcon, which owns, I think, 46% of the market share for intraocular lenses. In that year, they sold 7 million and made 920 million. In the same year, Auralab sold 1 million and made 5 million. So if you were to multiply Auralab by 7, we would have been like a $35 million company versus a $920 million company. So this is an example of how you sculpt not just costs, but your whole margin model and how you reach the end user by removing non-value added margin in the supply chain so that that results in affordability to the patient. Okay, I'm going to skip this slide just because in the interest of time. So it's all done with people, and I just wanted to show Dr. Nachir. She's the sister to Dr. Venkataswamy, the founder of Auralab, of Aravind. And it's really her efforts that created the advocacy for me to set up Auralab with the Auralab team. And I was just with her a couple of weeks ago. She's done, even when she was still in her surgical career time, we calculated that she had done over 500,000 cataract surgeries in her life. So I think she's like the highest performing surgeon. The other point I wanted to make in this slide is when we set up Auralab, and now what we're doing in optical, instead of doing so-called public-private partnership, begging private industry to help us, we decided let's just become that industry. And so that's how I started Auralab. I gathered NGO support, both for funding, but also to be our initial customers. And a lot of what I did was I said, give us money as advance against purchases, and then we'll give you product at really low cost. And that's how I got these initiatives going. So that the NGO sector, instead of begging the so-called corporate sector, we just became their competitor. And so when anyone talks about public-private partnership, they miss the whole point that if you gain control, then you don't need to do a public-private partnership. And these are some of the groups that we work with. So I found a lot of really great people to work with to develop these technologies. The suture was through a Grateful Dead connection, how I found my technology vendor. And I build companies around them. And then, as I mentioned before, we pay attention to intellectual property and trade secret law so that we can do everything by the book. And then the big aspect is gaining control of technology to be in control of manufacturing, distribution, and pricing to ensure affordability, use price to change the competitive landscape, taking into account in lower and middle income countries that the cost of stuff is the major cost in healthcare, more so than labor or other infrastructure costs. And so it's about demystifying product development, manufacturing, and regulatory costs, find out that it really doesn't cost that much, and engage extreme technical competence, take the help of IP lawyers, create novel channels that remove non-value-added margin, create companies that transform their industries in favor of lower income people, and sculpt the cost and the margins to result in affordability. So here we come to hearing. Here's some of the statistics. I'm sure you're all very familiar with them. 430 million have disabling hearing loss, and yet only 18 million hearing aids are sold each year. So that's a huge gap. And of course, that's the opportunity. And so this is Sound World Solutions, which I helped develop. And this is a self-fitting hearing aid. You can download an app to your smartphone and wirelessly test your hearing and program the device in a few minutes. And I would say that the features are the same as a $2,000 or $3,000 hearing aid, except we sell it for less than $100 in lower and middle income countries. And here's what the software looks like. It only takes a couple of minutes to test hearing and program the device automatically, and you can adjust it to your personal needs. You can also do the adjustments on the hearing aid. You don't need the app. There's a couple of preset settings. And these are all the features, which, same as all the other fancy hearing aids, I think. But the big problem is, as Dr. Lin was pointing out, is how do you convert need into demand? And I've been very successful in eye care, and I think I've been an abject failure in hearing care. But maybe that'll change if we put our minds together better on that. Sound World Solutions exists as a company, but it hasn't. It suffered a lot of setbacks to really transform the availability of hearing aids. I mean, we had this technology on the market in 2012, and we couldn't scale it. So anyway, I think that there's a lot to be done in hearing, and it's all about converting need into demand. And of course, lowering the price point is important, and figuring out how hearing technology gets incorporated into all headsets or earbuds or listening devices, where it's a wellness product instead of a hearing aid. That's my new idea based on discussions this morning with Dr. Lin. Let's just make it for everyone. Okay, so I'm going to quickly go through other technologies. I run an organization now called Carolink, based out of Baltimore, and Carolink sold its network of eye banks and decided to use its funding to create technologies to get around the big limitations for addressing corneal blindness, which are lack of corneal tissue and lack of trained corneal surgeons. So it's using its resources to leverage other resources. And here's some of the things that we're working on. We're working on a way to remove the front part of the cornea and put on a gel that enables regeneration of a healthy cornea, where we've completed our proof of concept, and we're now moving into product development and human studies. And then we're also working on early detection and treatment of keratitis using the right affordable hardware and algorithms. And some of the folks that we are working on that are here in the room today. And then early detection of keratoconus, again, with inexpensive hardware and algorithms for detection in large populations. And then we're looking to do innovative finance around all this. The other big project I'm working on is setting up an optical division at Oralab. There's a huge amount of people who have uncorrected refractive error. And I did a big study looking at what needs to be addressed. And basically, if you go upstream and buy lenses direct from the manufacturers, they're only a fraction of what they cost coming through a supply chain. And so we, at Oralab, we did that. And now we're just completing a feasibility study to get into manufacturing of lenses in India, because 90% of them come from China. And so we want to see how we can gain control of production to produce our own lenses and not have the political risk of lenses only coming from China. So that's another big project. I'm also similar to the Sound World Solution app, where consumers can adjust their hearing. We're working on a similar technology where a non-medical technician can do refraction on a tablet. It's being adapted from refraction that works via the internet, where it's on par with an optometrist using a 4-opter. And that's all coming soon. And then I'm working on a light adjustable lens where you can surgically implant an intraocular lens and then change its prescription post-operatively to address, decentration or errors in the measurements for the right prescription, and or surgically induced astigmatism. And you can also adjust it preoperatively in the manufacturing process and customize it for patients who have macular degeneration or keratoconus, so that you can adjust this freeform lens in a way that optimizes their visual acuity. And that's done through a hydrophobic acrylic lens with macromers that get light shined on them. And then it changes the positions of the macromers in a very precise way to change the curvature of the lens to enable better, better visual acuity. And then here's a group that I'm working with called Ashoka, also spun out of Hopkins here. It's usually you give an intravitreal injection for treating diabetic retinopathy or macular degeneration. They figured out a therapy that enables the patient to do a subcutaneous injection, just like insulin shots. And that in the animal studies, it was many times more effective in reversing disease than the market leader, aflibercept made by Regeneron. And so we're hoping the company has been open to seeing how they take this blockbuster drug and price it for affordability in developing countries, which is an example of, a company on its way to becoming big, deciding early on that they're going to have tiered pricing for these various lower income markets. Okay. And financing. So I'm going to just skip to what I'm working on now is to develop an investing pool, a diversified portfolio that combines both equity and debt, low cost, fully guaranteed debt to accompany the equity financing, kind of like as a credit enhancement. So this is for social enterprise medical technologies where they want to price for affordability in the developing world. I won't go into all those details because I think I want to finish up by saying this is about the middle way of capitalism. Philanthropy is not really sustainable, and you always have to reinvent yourself every year to raise money. And so, if the commercial sector is solely focused on return on investment, it's not incentivized to address human suffering. And so, how do you develop this middle way of capitalism? And I've given you many examples today that result in companies that are socially transforming and not just the usual corporate social responsibility, where service to others are baked into their organizational DNA, and where they use their profit and production capacity to serve low-income people. And this ends up, I don't even know why I'm showing this slide, but I was in Japan a few weeks ago, and my host knows that I'm really into wrestling and sumo wrestling, so they organized for me to see a sumo wrestling practice of sort of like the premier team in Japan. So I just had to show this because it was such a cool moment, and a lot of what I do is similar to sumo wrestling because it's the startup energy, the generative force. Because sumo wrestling takes place usually the match is over in 10 seconds, right? So I really appreciated that, and so I just thought I would throw that out. Thank you very much.
David, thank you so much. And I want to be mindful times 1 o'clock, all the trainings with me and David right afterwards. I think we